slides?
Yes.
Okay. Assalamu alaikum, everyone. Should we start, doctor?
Yeah, please go ahead.
So our topic for today is going to be rheumatic fever and rheumatic heart disease. These two topics, they might be a bit similar, but inshallah, by the end of this presentation, you will be able to tell the difference between them and for the treatment as well. Our agenda for today includes.
Sam, I cannot see the slide now. I don't know what happened. I'm not sure if other colleagues they are.
Nothing has changed from my side, doctor.
Okay, I can see it now.
Sure thing. So for the objectives of our today's topic, it's going to be elaborating on the epidemiology and etiology, talking about the pathophysiology of the disease, presentation and the clinical manifestations of the disease, how to investigate and diagnose, and what's the management and how can we prevent it. So before we start, I want just to clarify what's meant by rheumatic fever. So rheumatic fever is acute, short-lived multi-system autoimmune response. It occurs after having group A beta hemolytic streptococcus infection for 2 to 4 weeks following that infection, and it may progress to a chronic rheumatic heart disease up to 80% of the cases, which is a high percentage, and it might lead to permanent valve damage, as we will see in the pathophysiology of this disease. For the rheumatic heart disease, it will be caused by one or more than one incident of rheumatic fever, and it particularly affects the mitral as well as the aortic valves. These two valves are the most important in the disease, and you keep them always in mind. How it happens, so you will have an inflamed and scarred valve over time, and it's called valvulitis, and with time this valve will be dysfunctional. This will result by narrowing the valve itself, so the blood wouldn't be pumped effectively into circulation. And throughout the years, this will lead to heart failure due to the fatigue and exertion of the heart itself. For the rheumatic heart disease, it could be either acute or chronic. Acute, we can say acute rheumatoid heart disease if it's following one acute episode of rheumatic fever. That's it. And the clinical presentation of the disease is going to be pancarditis, which is inflammation of all three layers of the myocardium itself, or all the three layers of the heart. For the chronic phase of it, it will be several years after acute rheumatic fever, and it happens after a couple of episodes. And in this stage, we will have a permanent damage to the heart valve, and it can no longer be repaired or prevented by medications. For the epidemiology, rheumatic heart disease is the most common cause of acquired heart disease in the developing countries, especially between the age of 5 to 15 years in children, and it's a serious complication of rheumatic fever. So if you see a case of rheumatic fever, don't just neglect that child or treat him conservatively. You have to keep in mind the rheumatic heart disease is as one of the most common complications of rheumatic fever. And males and females are both affected equally, but the prognosis in females is much worse than males. For the etiology, as I said earlier on, it's following a group A beta hemolytic streptococcus infection, and we have one of the most common examples, Streptococcus pyogenes. Usually happens after an infection of the tonsils or the pharynx, sore throat or strep throat, and it could be following a skin infection, but this is in rare occasions. The transmission, it is transmitted through the direct contact with nose or throat secretions, or through the infective skin of the infected person. The virulence factor of this bacteria is M protein, and it's the major part of its virulence factors. So what's the pathogenesis in this disease? I think you can see my cursor in the slide itself. So we start by acute inflammation of the tonsils or the pharynx. And as you can see in the picture, it's inflamed. And as a response of that, our immune system will engulf the pathogen and start producing antibodies. And since the antibodies that's been produced against the virulence factor, which is the M protein, in this situation, our immune system, or let's say the valves of the heart, have a similar molecular mimicry towards the M protein. So the immune system doesn't recognize which one is self antigen and which one is self and which one is the pathogenic. So it starts attacking all of them. As a result of that, the heart valve will be damaged, and the disease will occur, and also the pathogen will start to vegetate on the valves themselves, leading to more severe manifestation of the disease. And this is known as type 2 hypersensitivity reaction. For the presentation, we have one of the common criteria, Jones criteria, and it's been elaborated by several letters, J, O, established by the heart shape in here, N, E, and S. For J, we have joint, particularly polyarthritis, and it's manifested as migratory arthritis. What do we mean by migratory? So it presents at the ankles, for example, at the beginning, then it moves to the hands, wrists, etc. And it lasts less than a week in each joint. For the myocardium, carditis, inflammation of the myocardium, and presented as pancarditis, inflammation of the whole heart. It will be endocarditis, inflammation of the endocardium itself, resulting in significant murmur and valvular damage or dysfunction. Myocarditis, leading to heart failure, and pericarditis, which will result in friction rub or pericardial infusion in this case. If it progresses to cardiac tamponade, this is a medical emergency. For N, subcutaneous nodules, it's a painless, pea-sized nodules presented at the extensor surfaces. I will show you an image in the upcoming slide, inshallah, and so you can see how it presents. E for erythema migranatum, which is an uncommon early manifestation rash over the trunk and limbs, presented as pink macules presented or spread outward. For S, which is one of the least common manifestations also, Sydenham chorea, which is sudden involuntary movements in the limbs, and the baby cannot control themselves. So this is a picture to establish the pathogenesis of the disease. As you can see here, the valves are affected in the endocarditis phase. In the myocarditis phase, we can see that the valves are dysfunctional and they cannot the heart cannot pump the blood effectively. And for the pancarditis, since we have an inflammation in the outer layer of the heart and the inner layer, we will have what's known as the frictional rub. And in this side, you can see the subcutaneous nodules, how it's elevated at the extensor side of the hand. And this is the erythema migranatum. For differential diagnosis, we always have to keep in mind systemic lupus erythematosus, infective endocarditis, systemic juvenile idiopathic arthritis, Kawasaki disease, and polyarthritis nodosa, because, as we said, one of the common manifestations is polyarthritis. For the diagnosis criteria, we can either follow the minor criteria or Jones criteria. Jones criteria, we already talked about it, so we will have one of the major criteria, which is polyarthritis and carditis, or two of the minor ones, which is the rash and the nodes that's present at the hand. For the minor criteria, we have fever, temperature is 38.2, arthralgia, previous rheumatic fever, And for the labs, we have leukocytosis, elevated erythrocyte, and prolonged PR interval on the ACG. For the investigation, we have the throat culture, and it's the gold standard in this case. We will take a swab from the throat itself and culture it and see what's the organism that will grow on our plate and which antibiotics would work in this case. We have also a positive rapid streptococcal antigen test. We can do it on the site or on the lab, and it will give us a positive result quickly. We have also elevated anti-streptococcal antibody titers, which is either anti-streptolysin O or anti-deoxy bauncalase B. And the serology, it will help in the diagnosis of acute rheumatic fever if the physical signs and symptoms are not present on the patient. Furthermore, we have acute phase reactants such as erythrocyte sedimentation rate and C-reactive proteins. These two are non-specific, yet they can help us to monitor the disease. Is it progressing, worsening, etc. For the blood culture, this is to rule out infective enterocarditis and bacteremia in case of severe manifestation or if the bacteria move to the bloodstream. CBC to identify if the patient is anemic or leukocytic. We can also use the ECG, as we said earlier on, to see if there are any T-wave elevation or to differentiate it between this disease and myocardial infarction, for example. And in the chest X-ray, it will help us to see the signs and we have talked about earlier on. If the heart is enlarged, if there is pericardial calcifications, or if we have pulmonary edema due to the heart failure as a later manifestation of the disease. For the management, we always start with penicillin V, unless the patient have penicillin allergy. Then we will move to cephalosporins or macrolides in this case. For the treatment of the acute episode of the disease, we will treat arthritis and fever by ibuprofen, paracetamol, naproxen in this case. The carditis and heart failure, we will tell the patient to bed rest, give him diuretics and vasodilators to help with the managing his heart failure problems. And for chorea, we will prescribe valproic acid, and we tell him to sit in a quiet area where he doesn't have any stimulation. This will help with his involuntary movements. Furthermore, we will keep in mind that if the baby have recurrent sore throat infections, we doesn't neglect this part. We have to pay attention for it, because if he had the episode once, that means he have the susceptibility to develop another episode of the disease. So we always keep it in mind. And we have to give the patient with recurrent infections a prophylaxis treatment. For the prophylaxis, we have two types, either primary or secondary. For the primary prophylactic prevention, we'll prescribe prompt antibiotics against group A strep, such as penicillin, or we will give him a secondary as for the secondary prevention, we will give him any type of antibiotic that's against group A strep. We could give him intramuscular injection of penicillin G, penzanthine for every 4 weeks, preventing him from developing the disease. So when do we give him the secondary prevention? We have 3 scenarios. Either the patient have rheumatic fever without carditis for 5 years, or until he develops or goes up to 21 years old, or the patient have rheumatic fever plus carditis within 10 years. We give him prophylaxis for 10 years or until he hits 21 years old. And the last, rheumatic fever plus carditis and permanent valvular disease, we will keep on giving him antibiotics for 10 years or until he goes to 40 years of age. Which one of them depends on which one is longer. For the prognosis of the disease, the prognosis of acute rheumatic fever has been improved over the past years due to the secondary antimicrobial prophylaxis. And the ultimate prognosis of the individual attack is related directly to the severity of the cardiac involvement. So someone who had acute rheumatic fever is different than someone who developed heart failure is different than someone who had permanent valvular damage. So each one will have different management plan. But the overall prognosis in this case is worse or the worst among the patients who have severe carditis. This is an article I found online, and it beautifully elaborates on the differences between acute rheumatic fever and acute heart disease, and it explains everything in terms of management, treatment, as well as the investigations. If you just click on the slide, or you can find the link at the references page. This brings us to the end of my presentation. I have just a couple of cases for you guys. So this is the first case. Who would like to read it?
I can read it.
Go ahead, Rand.
Okay, so a 14-year-old boy is brought to the physician because of fever, malaise, and severe right knee joint pain and swelling for 3 days. He also had episodes of abdominal pain, epistaxis, during this episode. 5 days ago, he had swelling and pain on his left ankle joint, which has since resolved. He reports having a sore throat 3 weeks ago, while he was camping in the woods, for which he received symptomatic treatment. His immunizations are up to date. His temperature is 38.7, pulse is 119 per minute, and his blood pressure is 90/60. Examination shows a swollen, tender right knee. Range of motion is limited. There are painless 3 to 4 millimeter nodules on the elbow, over the elbow. Cardiopulmonary examination is normal. His hemoglobin concentration is 12.3. Leukocyte count is 11,800, and his erythrocyte sedimentary rate is 63. Arthrocentesis of the right knee joint yields clear straw-colored fluid. Analysis of the synovial fluid shows a leukocyte count of 1,350 with 17% neutrophils. No organisms are identified on gram stain. Which of the following is most likely the diagnosis? A. Acute rheumatic fever. B. Septic arthritis. C. Acute lymphoblastic leukemia. D. Infective endocarditis. E. Lyme disease. F. Kawasaki disease. And G. Juvenile idiopathic arthritis. I would go with A. Acute rheumatic fever.
Excellent. So it's going to be acute rheumatic fever. Why? Because as we said, we already established two of the Jones criteria, which is migratory arthritis. He has only a pain in one knee and swelling, plus the nodule on his skin. So in this case, the answer is going to be acute rheumatic fever. Thank you so much, Arnold. Next question, who would like to read it?
I can read it.
Yes, go ahead, please.
A 9-year-old boy is brought to the emergency department because of progressively worsening shortness of breath for 3 days. He has had fever and malaise for the past 5 days. He had a sore throat 3 weeks ago and that resolved without treatment. He appears ill. His temperature is 38.6 degrees Celsius. Pulse is 98 per minute. Blood pressure is 84/62. Pulse oximetry on room air shows an oxygen saturation of 93%. Examination shows jugular venous distension and bilateral ankle edema. There are erythematous ring-shaped macules and patches over his trunk that are well demarcated. Auscultation of the chest shows crackles and the lung bases bilaterally. An S3 gallop is heard. His hemoglobin concentration is 12.2 grams per deciliter. Leukocyte count 13,600. Platelet count is 280,000. Urine analysis shows no abnormalities. X-ray of the chest shows cardiac ciliary enlargement with prominent vascular markings in both the lung fields. Which of the following is the most likely etiology of this patient's symptoms? A. Acute rheumatic fever. B. Viral myocarditis. C. SLE. D. Infection with the Borrelia. Or A. Kawasaki. I'd go with the acute rheumatic fever. A.
Excellent, Wa'ad. Thank you so much. So again, in this presentation or this case, the hints has been given already, such as the shortness of breath, sore throat for 3 weeks, and the crackles, bilateral pitting edema on the ankles, as well as the rash that is on the patient skin. And all of these are the manifestations of acute rheumatic fever disease. This is the end of my presentation. Thank you so much, guys, for listening. And if you have any questions, I will be more than happy to answer them.
يعطيك العافية يا أسامة. Well done. ما شاء الله. Outstanding presentation. Excellent skills presentation. So as Osama said, if there is any question for Osama or myself, we'll be happy to answer. But I have no further comment. Thank you, Osama.
Most welcome, Dr. يعطيك العافية.
يعطيك العافية أسامة. Thank you.
طيب, if there is no questions, we can move to the second presentation by Razan, titled Systemic Lupus Erythematosus. Razan, can you share your...
Doctor. Okay. Osama, could you please share my slide?
Sure, I'm working on it. It will take a minute to upload the presentation.
We can see the screen now, so.
Okay, thank you, Osama. Good morning, everyone. I'm Razan Hajazi, and today I will be talking about pediatric systemic lupus erythematosus. Our objectives today is, as you see. Okay, let's start by the definition. SLE is a multi-system autoimmune disease characterized by production of large amount of circulating autoantibodies. The exact cause is unknown. So we have a complex autoimmune disease affect all organ system due to alteration of both innate and adaptive immune system. Okay, what's the difference between the childhood and adulthood lupus? SLE is about 10 times more common in adults than in children. There is difference in disease manifestation, medication use, and disease severity between those with a childhood onset SLE as compared with the adult onset SLE. Children have a more fulminant disease onset and course than adults with SLE, resulting in 2 to 3 times higher mortality. There is a higher frequency of neurological and renal involvement at the time of diagnosis among children as compared with adults. And compared with adults, the disease onset during childhood carried a higher risk of developing lupus nephritis, malarial rash, anti-double-strand DNA antibody positivity, and hemolytic anemia. The frequency of some other immunological abnormalities is associated with the age at diagnosis. Anti-cardiolipin IgG, IgM antibody positivity appears to be significantly more common among children patients. Okay, so in children manifest similarly to adults, but with a greater severity and different treatment approaches. Okay, the epidemiology, it's more common in female than male. So the ratio of the female to male ratio is 10 to 1, and more likely to occur after the first decades. And 20% of all people who develop SLE develop it during childhood. And pubescent children, female to male ratio is 9 to 1. That's caused by high level of estrogen, or estrogen level. And pre-pubescent children, female to male ratio is 3:1, and it's highest in population of non-white people like African. And in KSA, in Saudi Arabia, the prevalence of system lupus erythematosus was estimated to be 19.28 per 100,000 population in the region. Etiology, the cause is unknown, but it could be caused by genetic predisposition or hormonal effect and environmental factors, hormonal factors or environmental factors. We start by environmental factors. The patient will have like he's smoking or have UV exposed to UV light or have Epstein-Barr virus infection, and he has a genetic predisposition to develop this disease like HLA-DR2 or HLA-DR3, or have a genetic deficiency of the classical pathway complement protein, and she's female and has hyperestrogenic states. So that's why some people develop SLE. But the exact cause is unknown. The pathophysiology, it's due to antibody development or autoimmune reaction. The autoantibody development is due to deficiency of the classical complement protein, and that's caused failure of macrophages to phagocytose immune complexes and apoptic cell material like plasma and nuclear antigen. This leads to dysregulated intolerance lymphocytes targeting normally hidden intracellular antigen, and lead to autoantibody production like ANA, anti-double-strand DNA. So apoptic cell material are not cleared properly, and they get exposed to immune system, and immune system is thought to become sensitized to this material. So next time they encounter such material, the body will mount the immune response toward the own protein and nuclear materials. Okay, autoimmune reaction. Maybe it's due to type 3 hypersensitivity or type 2 hypersensitivity. Type 3 hypersensitivity is most common in SLE in general, but type 2 is more common in children. So the type 3 hypersensitivity, it's due to antibody-antigen complex formation in microvasculature, and that formation lead to complement activation and inflammation and damage to the skin, kidney joints, multiple organs or systems. Type 2 hypersensitivity is IgG and IgM antibodies directed against antigen on cells like red blood cells that cause hemolytic anemia or cytopenia. Okay, clinical manifestations could be the patient will present like by constitutional manifestation like fatigue, fever, weight loss, or hematological petechia, cytopenia. Could be musculoskeletal like malacia, or serositis, pleuritis, and pericarditis effusion. And he has like heart problem like aortic valve lesion, coronary artery disease, pericarditis, myocarditis, endocarditis, or pneumonitis and lung, interstitial lung disease, pulmonary hypertension. Also vascular, like vasculitis and the thromboembolism manifestation. And some patients, especially children, develop a neurological manifestation like seizure, psychosis, personality changes, lupus cerebritis. And 90% of cases present with joints involvement. Often it's the earliest manifestation like arthritis and arthralgia, and maybe distal symmetrical polyarthritis. Okay. In the skin, 85% of cases has malar rash, butterfly rash, as you see in the first photo, and drainage phenomenon, which is a problem that causes decreased blood flow to the fingers, photosensitivity, discoid rash, as you see in the second picture, oral ulcers. The discoid rash is several sharply defined, partially confluent erythematous annular lesions, and the center of lesions appears atrophic, follicular bulging, hyperkeratotic follicle appearing as a white spot within the lesion, and discard hyperpigmented border can also be seen in the discoid rash. Also, oral ulcers, non-scarring alopecia, bilingual telangiectasis or telangiectasia. Okay, in the kidney, we can see nephritis with the proteinuria. The dangerous the dangerous complication of the SLE is lupus nephritis. And the pathogenesis is immune complex deposition in the mesangium and subendothelial or subepithelial spaces. Deposition of immune complexes lead to expansion and thickening of the mesangium, capillary wall, and glomerular basement membrane. Deposition of immune complex in the mesangium and subendothelial space lead to activation of a classical complement pathway and are manifested histologically by mesangial focal or diffuse proliferative glomerulonephritis. Injury is limited to glomerular epithelial cells when immune complexes is deposited in the subepithelial space, which is histologically presented as membranous nephropathy. So deposition in mesangium and subendothelial space is in communication with the vascular space, which is that's why complement pathway is activated here. Often manifests as a nephrotic syndrome. However, if the immune complex is deposited in subendothelial space, it's often manifested as a nephrotic syndrome, not nephrotic. Okay, elevated level of circulating tissue necrotic factor alpha correlate with active disease. So, tissue necrotic factor is expressed in renal tissue in lupus nephritis. We have many five classification of lupus nephritis. The first one is minimal mesangial lupus nephritis, which is rarely diagnosed because urinalysis appears normal, and there is minimal proteinuria and normal serum creatinine. So how is it diagnosed? Mesangial deposit and immunofluorescent. The second classification is mesangial proliferative lupus nephritis. We see here the mesangial hypercellularity, and the hypertension here is uncommon. While in focal lupus nephritis, hematuria and proteinuria is proteinuria present, and fewer than 50% of glomerular involvement, while in diffuse lupus nephritis more than 50% of glomerular involvement. And here the nephrotic syndrome will appear like hypertension and severe renal insufficiency. The last classification, lupus membranous nephropathy, is diffuse capillary wall thickening, basement membrane thickening, severe nephrotic syndrome. Okay, lupus nephritis, the features is persistent hematuria, cellular cast, proteinuria, elevated creatinine, and decreased GFR, hypocomplementemia. Diagnosis, renal biopsy is the gold standard. Renal biopsy is contraindication in the following situation, like solitary kidney, use of anticoagulants, uncorrected thrombocytopenia, and uncontrolled hypertension. Neonatal lupus syndrome is a rare syndrome, and it's associated with the transfer of maternal antibodies. The feature is congenital AV block, preorbital rash, cytopenia, elevated liver enzymes. Diagnosis based on the presence of heart block, rash, hematologic or hepatic involvement, autoantibody in either mother or neonate must be present. So it must be present to confirm the diagnosis. Treatment directed at specific organ involvement. Now the investigation. First of all, lab finding like CBC to see if there is anemia, thrombocytopenia, hemolysis, leukopenia. Complement blood test like decrease C3 and or C4. So both of them will increase or one of them will increase. Inflammatory marker elevated because it's inflammatory. It's the disease initiate inflammation and inflammatory process. So the elevated of ESR and C-reactive protein is seen. Urinalysis, proteinuria, hematuria, antibody test that confirm the diagnosis, like anti-double-strand DNA, anti-nuclear antibody, anti-SM antibodies, and antiphospholipid antibodies. Histopathology, lupus band test, directed immunofluorescent staining of antibody and complement deposit, found along the dermo-epidermal junction in affected as well as unaffected skin in patient with SLE, and kidney biopsy indicated in suspected lupus nephritis. So if we suspect the patient has lupus nephritis, we indicate the kidney biopsy. Imaging studies like assessment of organ or joint involvement. To diagnose the systemic lupus erythematosus, 4 or more criteria should meet from these 11 So like discoid rash, malar rash, neurological disorder like psychosis, for example, or seizure, immunological disorder, serositis, oral ulcer, arthritis, photosensitive rash, blood decreases, renal disorder, and positive anti-nuclear antibodies. So if 4 or more criteria are met and ANA is positive, we confirm the diagnosis. As we see here in the next slide, Osama. Okay, as we see here, at least 4 criteria met, and if ANA is positive, we see if it's positive and 4 criteria are met, we diagnose SLE. If ANA is negative, and less than 4 criteria the patient has, we exclude SLE. The complication, cardiovascular disease, like increased risk of thrombosis, antiphospholipid syndrome, increased risk of myocardial infarction and stroke because of accelerated atherosclerosis, and other comorbidities like macrophage activation syndrome, which caused by activation of T cells and macrophages, resulting in massive release of pro-inflammatory cytokines. And the clinical manifestation here include high fever, pancytopenia, hepatosplenomegaly, and elevated ferritin. Also, pneumonia is one of the complications, could be caused by bacteria, viruses, or opportunistic organism. And children here should receive both pneumococcal and influenza vaccines. Also, pancytopenia, non-Hodgkin lymphoma, and infection. Treatment, we counsel the patient on lifestyle factors like diet, exercise, stress, and avoid direct sunlight and use SPF. SLA patients are especially sensitive to UV rays, and make sure patient is immunized before immunosuppression. Symptoms relief also like NSAIDs, but we avoid ibuprofen. Immunosuppressive agents like hydroxychloroquine, cyclophosphamide, and glucocorticoid. Hydroxychloroquine, methotrexate is more commonly used in adults, not in children. Cyclophosphamide is more used for children, and glucocorticoids more commonly used for the treatment of the children. First of all, the standard therapy for all patients is hydroxychloroquine, but additional therapy could be used like glucocorticoid, immunosuppressive agents. So if the disease is mild, we use low-dose corticoid, but if it's severe, we use IV glucocorticoid. And now we have a new drug, which is pilimumab. And this one is the first targeted biological treatment for systemic lupus erythematosus, and it's administered as intravenous infusion. It's a human monoclonal antibody that inhibits B cell activating factor which also called B lymphocyte stimulator, by preventing the interaction of B lymphocyte stimulator with its 3 receptors and indirectly decrease the B cell survival and the production of autoantibodies. The most common side effect in this drug, it include bacterial infection such as bronchitis, infection in the lung, or infection of the urinary tract, diarrhea and nausea. Infections may be more likely in younger children more than older one, and arthralgia, headache, rash, infusion reactions such as urticaria and chest pain can occur. Hematological reactions such as neutropenia, thrombocytopenia have also been reported in some patients. The prognosis outcomes for SLE have improved significantly over the past several decades and depend largely on the organ systems that are involved. Worse prognosis are seen in patients with severe lupus nephritis or cerebritis with risk of chronic disabilities or progression to renal failure. With the current therapy for the disease and the success of renal transplantation, however, most patients live well into adulthood. Okay, I finished my presentation. I have 2 questions for you. So who would like to answer the first one?
Okay, I will read the first question.
Okay, go ahead, Sama.
Okay, so which of the following is true regarding SLE? We have A, hematuria and proteinuria indicate biopsy. B, anti-strep lysine or more than 200 international unit. C, low C8 and C6 and C7. I would go with A, hematuria and proteinuria indicating a biopsy.
Correct answer. Okay, next question.
I can read it.
Okay, go ahead, Lanud.
Okay. What are the specific autoantibodies for SLE? A, anti-Smith and anti-double-stranded DNA. B, anti-RNP and anti-double-stranded DNA. And C, anti-SSA and anti-double-stranded DNA. I would go for A.
Correct. Thank you. Okay. Do you have any question?
Thank you, Razan. Well done. Thank you for this comprehensive presentation. If there is no question, I have just a small comment. SLE, there is all that say SLE is a disease of 1,000 faces. So rarely to see 2 patients with the same manifestation. Yes, we are following this classification criteria as Razan mentioned, and we are looking for all these clinical manifestations, but rarely to see 2 patients that have identical manifestation. The second point, there is a long list of medication. Maybe Razan mentioned part of it. Like we have long list of immunosuppressive medication. We call it DMARS, including Imuran, Salsibt, cyclophosphamide, tacrolimus, and name it. In addition to biologic agent, Razan mentioned belimumab, but still we can use rituximab, another anti or B-cell depleted agent. Now, how do we choose this medication? Razan mentioned all patients will go for hydroxychloroquine unless they have reaction or allergy to this medication. But by default, all patients, they should go for this medication. And most of the patients, they will need the course of prednisone or corticosteroid. Now, for the other medication, immunosuppressive medication, we need to choose it or tailor it based on the clinical manifestation, or let me say, organ involvement. So based on that, we can decide which immunosuppressive medication we can choose. It was a very informative presentation, both of you. Thank you.
Thank you so much, Dr.
شكرا دكتور، يعطيك العافية.
والعافية، موفقين، طاب يومكم، مع السلامة.
مع السلامة دكتور. Have a nice day.